Welcome to episode 5 of Questions People Ask. Today, I am honored to have with us two guests, maybe a third later, but two guests from Martha's Vineyard area. Lea Hamner is an epidemiologist with the Martha's Vineyard tick program. And Aubrey Ryan is an emergency medicine physician assistant on Martha's Vineyard and a clinician at TickWise MV. Welcome.
Thank you for having us, Scott.
Hi, Scott. Thanks.
So we all just returned from a conference here outside of Chapel Hill in Raleigh, focusing on alpha-gal syndrome. And we called it our first annual scientific meeting. And I thought it might be, a good place to start in terms of just thinking through the things that we each sort of took away from that conference that were new and different. I'd tell you the things that stuck out to me. I really have been asking patients to use DEET and to spray DEET on their skin, and was always fairly careful to say, we don't want you to spray permethrin on your skin, but you can use that to treat your clothing or buy some clothing. But I think most of the time I was really more focused on DEET, and my sense is that from talking to the tick experts that were there, that's not the right message. The message really needs to be for Lone Star ticks that the money is in permethrin, and that's where you're going to get the best repellent and reduction in bites.
That's definitely our experience here on Martha's Vineyard, Scott. Having lived the difference between the two interventions, I have definitely noticed that tick bite prevention messaging from public health and CDC, because we are more focused on the threats of deer ticks, largely focused on repellents. And repellents are great because they're convenient. You can spray them when you're out and about. You don't have to prep so much for it. Whereas permethrin is the superior product for tick bite prevention of any tick bites, but you do have to prep. So there was a lot of messaging around repellents because we just thought that it was more convenient for people. However, Lone Star ticks are a little bit hardier and a little bit gnarlier. And the bully that takes your lunch money and tracks you down of the tick world. And so permethrin treated clothing has really proven to be the superior product for tick bite prevention against Lone Star ticks. And that does mean that people have to think ahead to treat their clothing ahead of time before they're going to use it. And so that's an extra step in terms of behavior change. But that's why we end up often in our community coming back to Insect Shield's product. They're the only ones that treat the clothing you send in. And so to make this an easier piece of my life, my husband's a landscaper. He could be terribly tick exposed if we don't take measures to protect him. So we gather up all our clothing once a year that we want to be treated, and we send it into Insect Shield to be treated. And the reason why that's a more effective treatment is very similar to if you buy waterproofing spray versus a waterproofed raincoat. The waterproofing lasts a whole lot longer when it's industrially treated with that waterproofing technology. And same thing with Insect Shield. You can buy the spray and you can spray it yourself, but to send it to Insect Shield where they can use their technology to hold that product in place longer means that it lasts 70 washings. So I get a whole year of peace of mind from that product. And that's just also been a lot easier, frankly, to fit into my routine is I know the clothing that's treated and I wear it.
One of the things that we were thinking about after the meeting was if you spray permethrin yourself on your clothing, does it pose a risk then to wear that clothing into your home?
So honestly, the permethrin that we have has been well studied and to be safe for 50 years. It's been around that long in its spray form and used the long-term technology to be able to hold it on the clothing. That was developed 20 years ago, but it's the same product. It's just the technology used to hold it there. But once it's dry, it's a very stable molecule, and then it doesn't rub off onto other things. And if it does rub off, it's a very small amount. And it's toxic to ticks, but it's not toxic to people. We are a different creature. We are a much larger creature. And it has been well established to be safe, even for children to wear, even for pregnant women or lactating women to wear. There's no warning label on permethrin treated clothing. The one caveat for spraying permethrin, wet permethrin, is around cats. Cats don't have the liver enzyme that we do to break permethrin down. And also their grooming behavior, they lick themselves. So if you were to spray permethrin and it were to get on the cat, they would lick themselves and consume the permethrin. I have a cat. I still use permethrin all the time. What I do is I just wait for him to go down for one of his epic naps, and I just close him in the bedroom, and then I do my spraying. The spray dries in like 5 hours, and then I let him back out. And that's been fine. I'll wear permethrin treated clothing. The cat can be on my lap. We're not worried about that. The veterinarians, there's a fabulous NPR recap of where the veterinarians were worried. They were worried that cats would be people who would use dog products. Dogs have very high permethrin concentration products because they're not affected by it. They were worried that people were going to use dog products on cats. And they were like, please don't do that. So that's the main warning label around permethrin in cats. But otherwise, it's very safe.
It's a repellent, but it doesn't kill ticks.
Oh, I'm happy to tell you that the good news, actually it does. So it's actually an insecticide. If the tick is exposed to the permethrin long enough, it takes a certain amount of time, 3 minutes, it will actually kill the tick. It doesn't kill them immediately. What happens is they're crawling on your clothing and they'll pretty much fall off. It's like walking on hot lava for them. And I've literally watched a Lone Star tick crawl up my pant leg, and it won't get above my belt buckle before it's like abandoned ship. Then if you were to sit and watch that Lone Star tick, it would take about an hour for it to fully die, but it basically curls its little legs in and dies from the permethrin exposure. So you can do your part by wearing permethrin.
Yeah. So even though it is hot lava, which is kind of like repelling them, it ultimately kills them.
Mm-hmm.
Okay. Yeah. So now I learned 2 things about permethrin, one of which took place outside of the conference and happened here.
And it definitely also helps for the sake of kind of cementing this piece about how I dress. I presented at the conference. I showed the conference the number of ticks you can find in my backyard. Everyone was horrified. I still don't get bites in my own backyard, even with the number of ticks that you can find in my backyard. And key to that is permethrin treated clothing, for sure. The other thing is tucking. If a tick can get under your pant leg and get to your skin quickly, yes, they might still be exposed to permethrin in the process, but they're going to bite you first. So it's very important to make sure to not let them get under the clothing. You want them to walk over the clothing. And so really great clothing that we already see a lot of people wearing are like leggings. Leggings are fabulous tick protection. They're not going to get under those. Or joggers with a tight fitting cuff at the ankle. And then you can definitely do socks over pants, but we also just have other pieces of clothing that actually are tight around the ankle where the tick is still going to go over. And so that works great.
So maybe not fashionable, but functional.
I don't know. Leggings are having their heyday. They're very fashionable. They've been fashionable for 10 years.
And now I understand why during the meeting you mentioned the idea of a pet bed that may have permethrin, because at one point I was thinking, well, that's just going to drive the ticks off the pet into the home and onto us. But now I get it, because it's actually going to kill them.
Yeah, because it's not just a repellent. So I have a permethrin treated blanket, and that blanket is on my bed because my cat likes to sleep in my bed. And I was finding that ticks were getting off of the cat and coming to find me. And I hated that. And so I put a permethrin treated blanket on top of my bed that's dry, and the cat sleeps on that, no problem. I do not get ticks coming to find me now anymore, which is really great.
It's a win-win. Okay, Aubrey, what did you learn?
Oh, well, as you know, I was beside myself with the wealth of information that I was provided at this gathering of experts. I had a lot of things that I was really focused on, and the top few. First of all, I was really fascinated by the studies of the knockout pigs, the gal-safe pigs that do not themselves have alpha-gal, and then we're sort of induced to have alpha gal sensitization, and looking at what happened to heart valves. I thought that was really fascinating. It's a question I get asked a lot as a clinician, of patients who either may need a heart valve in the near future and have to make a decision about a bioprosthetic valve, whether it's porcine derived or otherwise. So I thought that that was really quite intriguing, and certainly a lot more studies to come. But I know we also talked a little bit about studies in these patients who had great perioperative outcomes when we prepared in advance for the possibility of an allergic reaction. And that was very promising as well, to see that that issue can be managed. Because for a patient to have make a decision about potentially life-saving cardiac device implantation while also having alpha-gal syndrome just adds a lot of undue stress or additional stress. So those cardiac studies were fascinating. I think a big piece for me was the focus on mental health. I find myself in a role of not just doing diagnostics and treatment, but a lot of counseling. As we all know, alpha gal syndrome is highly disruptive to patients' lives. And it's not just the physical manifestations, it's the emotional ones, the social ones, not being able to attend dinner parties for fear of accidental exposure, going to restaurants, all those things that we do together as the social beings that we are as humans are impacted by alpha gal, and the focus on mental health. And I believe the phrase that I heard used was the invisible work of keeping safe, and how exhausting that can be for patients, reading labels, wondering when they're going to have a response, if they're going to have a response. Are they going to be in a place where they have access to care if they have a response and their EpiPen isn't enough? Saying no to family events, it really impacted me. And I think having those resources available for any clinician in any field that's dealing with a patient with alpha gal syndrome is key. So to see how much work is going into providing those resources and also collecting the data on how patients are impacted in a social emotional way, as well as the economic piece. That was also quite fascinating to me to learn about farmers and people who used to work in fields where they are being exposed constantly to the alpha gal sugar in a way that could potentially trigger their allergy. How, one, they may lose their livelihood or have to make significant changes to their livelihood, and just the economic impact of the care that they have to seek, whether it's travel to places where specialists are more aware of and trained in these fields. The cost of certain tests or medications is also a huge piece of this. So I thought that that was a really wonderful amount of information, and that was implemented into this conference.
No, very true. And salient points. I took some of those myself. We think about emergency medicine as fast-paced
Yeah.
and quick visits. You form a clinical impression based on a history, and maybe you do some labs or studies, and then the whole point is to take care of someone quickly, and because you probably have a long line waiting. How do you personally
Yeah.
balance that time pressure that has to be there with these discussions that take time? And you're probably one of the primary clinical resources for people on the island, but you're in the emergency medicine space. So how do you balance that?
It's very, very difficult. And I find myself torn between needing to move quickly, but also understanding that, especially when it comes to something like alpha gal that can change your life so significantly and be such a danger, I really do feel that a lot more time is required to have conversations with these patients. And in the ER in general, I think our patient population nationwide in ERs has changed. It's very hard to access primary care. It can take time. It is difficult to connect with specialists. So a lot of times the ER is a place where people come for things that might not necessarily be an emergency, but give you quick access to care. So in those moments, I try to provide as much education as possible, and I do take the extra time. It's simply imperative. I've also spent a lot of time drafting discharge instructions that are highly specified to you potentially have alpha gal. For the moment, this is what I would recommend until you have a more nuanced conversation with either your primary care clinician or an allergist and nutritionist. So I make a lot broader recommendations in the emergency setting than I do in my outpatient work, which I can talk about in a second, simply to keep people safe. In the ER setting, if I'm suspicious that you have alpha gal syndrome, I will send you home with the most broad-based recommendations. Avoid all mammalian products for the moment. Let's carry an EpiPen. Let's carry Benadryl. Here are the signs and symptoms. Here are the foods. And I have an entire document that I've now created. So it's less of a conversation in the moment and something I can hand you. That document also contains a lot of resources for sound scientific information, including AlphaGo Info, our local public health agencies for information about ticks. So in the moment, that's kind of how I get around it. Now, that said, I also get a lot of phone calls later about positive test results, which unfortunately take several days. So I will have conversations with patients that I've seen, but also patients I didn't see clinically that happened to catch me as a clinician. And those patients need more than a 5-minute phone call. And it's been very, very hard in the ER setting. So I've tried to supplement. It's part of why I sought doing some outside just tick related work, including alpha-gal, because I really do feel that this is a subset of patients that need a lot of guidance in terms of what to avoid, but they also need a lot of conversation and time to ask a lot of questions. The questions are sometimes the same, but they're very nuanced and different for everyone. So having that conversation in the outpatient work that I do at TickWise has actually been the most rewarding because I get to actually sit and answer all the questions that I don't have time for in the ER. And then the other piece of that has been the public education. I'm trying very hard to get out there and give talks, oftentimes with Lea and with Patrick, to talk in a more holistic sense about ticks and the risks on the island, not just pertaining to alpha-gal, but often we will have conversations just about alpha-gal, which provide an educational forum that hopefully answers all of the questions patients have and also gives them an opportunity to ask questions they haven't had answered by their clinicians, either because they haven't seen one yet or the clinician didn't know. So the public education piece and the outreach outside of the ER has really helped balance and mitigate that very real issue of not having the kind of time I'd like to have to reassure my patients in the moment in the emergency department. But at least I can send them out with documentation and a lot of literature. I tell them you're going to go home with lots of reading to do. And hopefully that stands in the interim until they can have a more nuanced conversation, whether it be with me or another specialist.
Can they come see you in the outpatient setting through the
Yes.
TickWise MD? They can make an appointment with you?
Yeah. So basically, the goal of TickWise MV was to sort of fill some of those gaps. We have a lot of clinicians on the island, and increasingly more so at the hospital and some other clinics on the island that are also trying to do the same sort of thing. What I do is I will do consultation if you simply want to sit and have a conversation. Like, I don't know much about ticks. What do I do? What do I need to worry about? Is this a tick? Basic stuff about prevention, basic stuff about removal, all that sort of tick education. What environments do they live in? What can I do in my backyard? The basic stuff. So I can sit and simply have a conversation with you about that in advance of you even ever having had a tick bite. In addition, if you have had a tick bite, whether it was 6 months ago or you just pulled one off or it's still attached, if you don't know what to do, I want to provide a resource where I can either come to you or we can have a little telemedicine visit and say, oh, yeah, you don't need to worry about Lyme prophylaxis with that particular tick. That's a lone star. It doesn't carry Lyme. Or, hey, it's not been attached for very long. Your risk of transmission of most of the infectious things are pretty low. Or, yes, that's a lone star tick. And we have some things we need to talk and discuss. That's the biggest question I have is, am I going to get alpha-gal? And those are the longest conversations. Being able to say to somebody or having to say to somebody, you may never ever develop alpha-gal syndrome. And no, you don't need testing today. And you don't need testing 6 weeks from now unless you develop symptoms. So on top of simply, do you need to get tested? What can we do to prevent you from getting bitten in the first place? And what do you need to worry about? I will also help you determine when you need to get tested, be it for alpha-gal or any of the other local tick-borne illnesses that we have. And then we'll walk through the interpretation of those results and what options are available to you for treatment that are grounded in science and may help you get through it. I will also provide additional resources if you need to speak to a nutritionist, if you need a higher level of care and are having severe allergies and need to see an allergist, I'll make sure that I can get you connected there. And that's pretty much it. And at the end of the day, I think 80%, maybe a little bit less of what I do is simply reassurance and providing information, with the goal being that someone leaves my space going, okay, I know what I need to worry about. I got some of the answers that I need. I jokingly titled my talk for the public, Everything You Want to Know About Alpha-gal, which is just in and of itself a misnomer because there's so much we don't know. But hopefully it is providing some additional reassurance. And I just think having a place for people to turn where I'm not looking at my watch going, oh my gosh, I have 3 other patients in an emergency coming in the door. This time is just for this individual patient. And I think that in most medical settings and with most medical issues goes a long way. And we've sort of come away from that, given our current medical system. Spending time allowing a patient to feel seen and heard is invaluable. And I think alpha-gal is a great example of something that requires a lot more than, hey, you tested positive, I'll see you in a month.
Right. So many unknowns.
Yeah.
And Lea, I want to get to your takeaways from the meeting, but if people are tuning in and haven't listened maybe to episode 1 or 2, I want to just real quickly say, if you get a Lone Star tick bite, we are confident that it takes several weeks for the alpha-gal specific IgE to turn positive. So there is no need to rush to get a blood test for alpha-gal unless perhaps it's a recurrence for you. But if you've not had it before, you don't need to rush out and get a blood test for alpha-gal specific IgE in the hours after a tick bite. We typically ask people maybe to think on the 4 to 6 week time horizon, because you got to give time for that IgE response to develop.
Because I do have patients that ask me, okay, so I don't need to be tested today. Should I get tested in 6 weeks? And I typically tell them, that's not necessary either unless you have symptoms. Is that the correct guidance still? Because my understanding is, and I know we're going to get to dig into this a little bit more, that you are very likely, and many people are very likely to test positive, but that does not mean that you have the syndrome. And really helping patients understand the distinction between sensitization and syndrome is important, especially in a current climate where there is a lot of indiscriminate testing going on, in large part because clinicians don't yet understand when to test and when not to. And the value of that test in the presence of symptoms. I find, it's not very black and white with alpha-gal. And a lot of it has to do with an individual patient's comfort with risk and the unknown. And I certainly, as I'm sure you do too, I have a lot of patients that are like, I've had a Lone Star tick bite. I'm worried I might have alpha-gal. And they eliminate everything from their diets because of things that they've heard, which are factually based. There are people that have had horrible anaphylactic reactions. So, having these individualized conversations with different patients, one of whom might say, I'm never going to touch this stuff again until I'm sure. Others that continue to do exactly what they've been doing until they have a sense that they may be actually developing an allergic syndrome. Neither of these approaches are wrong. And I think that's so unusual in medicine, where there's this guidebook, and maybe one day we'll have one with additional research and data. But right now we're in a place where there really isn't a clear guidebook, and you can have different conversations and different recommendations with different patients, depending on the setting that you're in as a clinician, the time you have to have the conversation, and the details you can get about their diet and their responses. I think that's unusual. And unfortunately, it's hard for patients to hear that clinicians don't have an answer. And I think sometimes clinicians are afraid to say, I don't know. We're not sure yet. But at the end of the day, that kind of honesty drives that trust relationship between a clinician and a patient, where we're able to say, this is not information we have right now. Let's come up with some recommendations that make you feel the most comfortable with the data that we do know. And again, might be different for everyone. And I know Lea does this too, but we explain a lot to patients and the public that this is an evolving scenario right now. What I'm telling you at a lecture today might be very different, or might include a lot of different information and recommendations 3 or 4 months from now as these studies give us new information. So I think that's a tricky one for all involved.
Yeah, it is. And you're completely correct that what is one approach for one patient may not at all be the approach for the other. I definitely have people who will say, I'm going to avoid red meat because I had a tick bite. I want to check labs in 4 to 6 weeks. If I'm positive, we'll do a challenge. If I'm negative, then I'll just reintroduce it. So there are multiple ways to play this. And it reflects what your point was, that it really needs to be an individual discussion and a tailored approach.
If I may leverage this point into one of my favorite exercises of the conference, is we ended with, where are we going? What are we going to do next? And what are the most important things to focus on in the near term versus the long term? Scott, what would you, as one of the experts in the field who's been working on this far longer than Aubrey and I have, what are the first major scientific questions that we need to work on in the short term to resolve this unknown? One of them is just simply who, in my mind, what is my risk from a Lone Star tick bite, and what elevates the risk from one person to the next. But if you could kind of tease that out for folks who aren't so familiar with what has been solved and what still has yet to be solved.
It's an excellent point that we don't know what an individual's risk is from a single bite, or say you have multiple seed tick or larval tick bites. We need a study where we enroll people and have a baseline blood test, a questionnaire. We know that either they are or are not allergic to alpha gal, and then we follow them and have intervals where they come and say, hey, I had a bite, and we can get a blood sample fairly quickly to start to define what is that risk from a bite or series of bites. And then that begs the next question, which is, once you know a portion of the tick risk, we then have to figure out what's the host risk. And there probably are different factors, genetics, microbiome, et cetera, that each of us as human hosts for these tick bites bring to the table. And our risks may not be equivalent. I mean, we know this about the blood group side of it. If you're B or AB, you seem less likely to get alpha gal IgE. So it's certainly a study that we need to do. I think the critical part of this is going to have like community involvement and the ability to get a blood sample fairly quickly.
Yeah, because that's the thing about research is beautiful study designs also require vested participants. And it's not a small lift to be involved in a prospective cohort study. These can go on for some time and they're one of the most powerful study designs in terms of an observational study design that can actually help tease apart causative factors and the real reasons why our bodies do the things that they do. But one of the most prominent prospective cohort studies was the HIV cohort study that really went on for years, and it solved a lot of scientific questions. And so that's something I would love to see in the field, but it will take time to, of course, once the study starts, to then have enough data, have enough time to really tease this apart. So I won't get my answers next month, is what I'm saying.
But we probably should put a plug in for the residents, whether they are permanent residents or seasonal residents of Martha's Vineyard, because they might be a great group to enroll in such a study.
I have to
We,
say, there's probably a lot of interest. I mean, I've had so many people, you don't often have people lining up to sign up for scientific studies. And I think we have a population here that is so eager to have answers that they're like, please enroll me. So I think it's going to be really interesting to see. And it's also really lovely to see how a population wants to get together to help solve some of these problems. Yeah.
I will just reflect on my public health career that it is kind of interesting how different the engagement is with tick-borne illness and alpha-gal syndrome compared to anything else that I've worked on. I've worked on STIs, I've worked on tuberculosis, I've worked on the opioid crisis. Like, no one wants to talk to me about that, but sure do want to talk to me about their tick-borne disease experience. And I think that, frankly, that should be honored, that patients are involved, that patients are interested in participating with science and are interested in engaging with public health in that way. And also it should be a moment to seize upon that relationship productively, in that, like, let's seize on the moment and move some science forward.
Yeah, I've wondered, because the island isn't, like, you have a contained amount of land. You've both been in some of the media portion of this, TV, print, etc. Do y'all get recognized at the grocery store or the library on island?
Yes. I mean,
Yeah.
but by our own community, though.
Yeah.
It's a small enough island, and we do so many outreach and engagement efforts that our community knows us,
Yeah.
for sure. And even when they don't recognize us, we can hear conversations. Aubrey, I'm sure you've experienced it. I've been in the grocery store and I hear someone
Yes.
talking about their alpha-gal syndrome
You have
and
to
trying
control yourself.
yeah, you also have to know to not butt in, is the other thing. Cause like
Yeah.
you want to be helpful, but also you know that if the moment you start being helpful, you're in for a 45-minute conversation. So if I have somewhere to be, we're not doing that right now. But it is definitely something I've found a lot more engagement with. I get a lot of emails from folks who see me, but also it's interesting because I've definitely had folks from graduate school or past folks who are reaching out and asking me questions from other parts of my life that I haven't seen in a long time, who say, Lea, can I have a friend who's recently diagnosed with alpha gal reach out to you? Like, he has questions, and they don't live here. But because we are making waves in terms of explaining kind of how Martha's Vineyard has been impacted. And one thing I do want to get to in this podcast is kind of comparing what is happening on Martha's Vineyard to other parts of the country, because I would argue what the big differentiator here is change, not maybe overall burden, because I think still our friends in Missouri and Arkansas and Kentucky are having a really hard go of it when it comes to alpha-gal syndrome. But we have had a lot of change here, like in the last 5 years alone, in terms of how much alpha-gal syndrome becomes a part of our conversations in our lives here. So that's made for a bit of a media frenzy. People also like to talk about Martha's Vineyard, good or bad or ugly, in the national media. So we're hopeful that that is productive, in that it's leading to awareness, and awareness helps people find a diagnosis sooner, and that could potentially save a life. So that's kind of our ethos about this. But we definitely also get the Daily Mail headlines that say billionaire enclave terrorized by tiny ticks or something like that, that are just sensationalist and not helpful, and frankly not interested in telling the alpha-gal story, and more interested in dragging a community.
Yeah.
But there are good reporters there that we've engaged with that have really tried to explain what alpha-gal syndrome is, what's happening here, how it contrasts or is similar to other places. And I really commend a reporter that recently published in the New Yorker, Burkhard Bilger, for providing the Martha's Vineyard story in context of the national context, but also the global context. I think that that's something that's lost on most stories I've seen in the United States, is that alpha-gal syndrome is a global health issue. And that's something that was touched on a little bit at the conference.
Yeah, I have to say, as someone, and I know Lea, we've been eat, sleeping, and breathing Martha's Vineyard tick-related issues. And I think, whenever you have a small community, it's easy, I think, for the people in the community to see this as an issue that's entirely unique, to them. And Martha's Vineyard certainly has some geographic and ecological elements that make our tick-borne illness issue, including alpha-gal, extremely unique and very difficult to manage. Being an island, and our explosive tick population, or deer population, as you know, which is the breeding ground for these ticks. But going to this conference and really getting a sense of the national efforts and the national impacts that vary from state to state and ecology to ecology was very eye-opening to me, and also really important to see. We're not the only group affected or the only community affected. The media coverage is so interesting because it really has, in my mind, been a double-edged sword, right? Everybody's interested in clicks and traffic. And in order to do that, you have to have an eye-grabbing, often alarmist headline, which is unfair. It promotes, there's a lot of misinformation about health and science and what are risks and what are you in danger of. And after we went through on a global level with COVID, the pump is really primed for fear. Yet, with that said, that national coverage has brought a lot of attention to communities that are significantly at higher risk, but also pointing out the fact that alpha-gal is not new. Yes, Martha's Vineyard is in the headlines all of a sudden, again, because of its the way it's understood to be this sort of billionaire enclave, when it's often missed that there are a lot of underserved communities here. There are average people, there are impoverished people, people that don't have access to care, that don't have finances. But I think it's been great to also help these communities that have been dealing clearly with alpha-gal for far longer than we have. And it's going to bring research opportunities and funding, more public health data is what we need in order to help solve some of these problems. So it's tough with the media sometimes. I'm not always thrilled with what they have to say. Even the piece that came out, the op-ed in the New York Times the other day, had excellent information and a classic clickbait title about, we need to go to war with ticks. There's a really subtle balance that we have to strike between making sure there's enough attention on these issues, but not so much that we have driven people to a place of fear and panic.
Yeah, no, it's a great point. One of the things that I was reflecting on in thinking about y'all's work and Martha's Vineyard and the unique opportunities, but also challenges there, are that I assume people are coming in large part, like the vacationers are there for recreation or like hobbies, leisure time, you know, day to day wise, like we're all going to work, and sure, for some of us that is outside, but I would imagine one of the hardest things from a public health standpoint has to be that X percentage of people who are coming to Martha's Vineyard have no desire to stay inside. Like they are there to be outside and like in all these areas.
Absolutely. We have kind of three different communities, and it requires three different approaches just in terms of seasonality and who's here. We have the year-rounders, who are hardworking folk, and often large portion are trades and outdoor workers. But just also reaching those folks and where they get their information is very different than our seasonal residents who come from like Memorial Day to Labor Day and have second homes here. And then our just day trippers are a completely different group. And being able to get good information to people who aren't so well accustomed to tick bite prevention. Like our year-rounders know a lot about what they need to do. When we were doing school education, there were kids who could recite my talking points before I even got to them. Like, they know what they're supposed to do and they know how to take care of themselves. That's completely different than what our seasonal or our tourist groups know. They're just not used to that. Maybe they're coming from a city where they don't have that sort of exposure. And they do. They come to the vineyard for the beauty, the nature. That's the point. And so being able to help them implement new habits is a challenge. But I try to get to them with also the point that we wear sunscreen when we go to the beach. We already take measures in a summertime community for a summertime activity outdoors to protect ourselves. And so could we layer on one more thing? Like, you think about mosquitoes and they think about bug spray without really having too much fear. And so we can do things to protect ourselves that work now, and being able to help them understand that is part of my job, large part of my job. And one of the things that is a little bit of a challenge is when we say permethrin treated clothing is our favorite resource, is again the planning that takes, as opposed to grabbing sunscreen at the grocery store and just applying it when you need it. Repellents have that feature also. And that's why repellents are still a convenient, use what is available to you and that works. Whatever extra step you can take that can fit into your life, I support it. Don't let perfection be the enemy of progress, please. But if we can go towards the better and more effective strategies, I love to see it. I have seen, because of our media coverage, more permethrin treated clothing than I've ever seen in my life here on Martha's Vineyard. And so that does make me see progress. And so the fact that folks are taking it seriously and taking the protective measures that work is progress in the right direction.
I think just some other things that I took from the conference, aside from just like, I wrote down so many things that I've been looking up and actively implementing into my educational stuff and just my own practice. Sharon Forsyth from Alpha Gal Info. First of all, like another person that I feel like I know, but hadn't met in person. And it was really lovely to meet her. That was a wonderful piece of the collective presentations to be able to see like what's being done. I think she phrased it as the current state of Alpha Gal advocacy. It's so important, obviously, for a group of clinicians and epidemiologists and researchers to know this, but for the public to be aware of how much is being done behind the scenes they may not be aware of, in terms of, even just the trying to get the FDA to include the alpha-gal sugar on its list of allergens so we can require food labeling. I understand that it's complicated on a lot of levels, but there is a lot of advocacy. And I took a lot of that information home and have been relaying that to my patients who feel alone. They may not know where to turn for information, but simply knowing that this is being worked on, not just on these small local levels, but in the States and as a nation as a whole. There's so much advocacy. So that was wonderful to learn, and great information for patients. I think just from a research standpoint, and I don't know how much it really plays into what we're going to do about alpha-gal, if it changes anything about our approach, but some of them are nuanced scientific information about the amount of alpha-gal in the saliva of ticks and when it's highest, and whether it's the larval stage, the nymph phase, the adult phase, was really fascinating. And I certainly want to follow that. I get asked all the time too about the Ixodes ticks, which used to be our dominant tick on the island. It's pretty clearly the Lone Star at this point. But knowing, as we have for some time, that the Ixodes species are the primary vectors for transmitting alpha-gal risk in many other places in the world. But here we're so focused on the Lone Star tick. I know we had those 2 studies that came out about one patient in Maine and 2 in Washington. I believe both of those studies were in 2024, and what that means for us. And I have had patients ask about that. And I simply said to them, it really doesn't change anything. It's still about prevention. It's prevention that works. Whether you're getting bitten by a Lone Star tick or a deer tick, if we do find out that Ixodes species have a role or play some significant role in alpha-gal syndrome locally, it really doesn't change too much for us. We don't want tick bites, period. So I'm looking forward to seeing how some of that research continues to sort of unfold. Those were the two other pieces that I took away from the conference that I'll be following really closely.
Yeah, absolutely. I mean, excellent thoughts. And I think it is helpful to know that people are working on AGS from lots of different angles, and advocacy and what's happening in Washington and at the state levels is reassuring in some ways. If you're out there thinking like, I've had this blood test, I've got this allergy, and like nothing's really happening, there are activities going on, and it was great to
Yes.
hear about that. I agree.
And it's good for our public health agents because I think someone made a comment at the conference, it might have been you, Lea, about how public health, unfortunately, is sort of invisible to most people until there's a crisis. And then all of a sudden, people are aware of what you do. And, in large part, the work that was done on the public health level is what drove Massachusetts to finally make alpha-gal reportable in our state. And that's such a huge boon for us. So I think this whole situation locally has really helped people understand the value of public health data and what public health agents do, including our disease trackers who, are making how many phone calls a day to follow up with alpha-gal cases. I think it's really important for the community to know that they're being advocated for, but also that these people exist doing this hard work behind the scenes to get this information for us.
The conference really showcased the interdisciplinary nature of this particular topic. Vector-borne disease in general, I would say, but because this is also moving into allergy and all these other spaces of in advocacy and mental health, and I thought the conference did a beautiful job of exposing professionals in their field to other types of thinking and other aspects of the field that they hadn't really thought of before, or had surface level information that we were able to dig deeper in how we could create cross-sector kind of collaborations and for the benefit of patients. So that was a beautiful piece of the conference. So kudos to you, Scott, as one of the planning committee people putting this together. I'm looking forward to seeing more of that going forward. I think that this is a field that's thinking very proactively about that cross-sector collaboration.
I had to contain myself at the end when there was a question about how frequently should we meet. And there was like every other year, once a year, twice a year. And I was like, oh, twice a year. But I realized that was probably overkill. And I was like, okay, every year. But this is how excited I am for more of
Yeah,
this kind of interdisciplinary collaboration.
I
So
know.
I'm looking
Yeah.
forward to like, who knows what additional new information we'll have. Do we want to talk at all about the very interesting MMWR study?
Yes,
Yeah.
I do. I want to
Oh.
talk about this. Scott, you were part of that paper. Eleanor Saunders, Johanna Salzer, CDC, UNC. It's a
Yes.
great paper,
Mhm.
and it provides an interesting piece of context that I would love to kind of talk about how this data is different than what the Vineyard has, because our numbers are making the rounds and folks are talking about the data from the Vineyard, and there's nuance to how that data is collected on the Vineyard versus how your data was collected. So if you could talk a bit about that MMWR and how you went about it.
Sure. And then we'll have you fill in how it fits in context or perhaps not in context with the data from On Island and Martha's Vineyard. So the most recent MMWR report was a, the start of a national seroprevalence survey, and this this one came from blood donors that were selected mainly in consultation with the CDC and um, the epidemiologists at the rickettsial zoonoses branch to think about which states were high prevalence for AGS, which were probably low prevalence and which were kind of anomalies, if you will. And so what we did was in partnership with CTS, which is a national blood banking outfit, they were able to pull 300 random, well, kind of random, but 300 representative samples from blood donors in these 10 states. So 3,000 total. And then we ran those for the presence of alpha gal IgE. Important to note that these are, basically completely de-identified samples only known to the testing service portion. And these are not cases or patients that were seen by an allergist or referred for testing. These are just random blood donors, and we're trying to establish what the baseline seroprevalence of the alpha gal IgE is. So it doesn't mean that these people actually have AGS at all. They can just be, we call it sensitized in the allergy field, but it's probably in many ways more appropriately considered a false positive. And we think that probably just comes from a history of tick bites. So there were 5 states in particular that had fairly high levels of alpha gal IgE seroprevalence. And we're thinking about Arkansas, Missouri, and Kentucky. And those levels, are in like the upper 20s to 30%. So 100 of 300 blood donors tested IgE positive in some of those states. And you contrast that with states like New Mexico, where there's very little, maybe one positive in the whole 300. So that's the background of that study. And we hope to do more. We would love to make it truly more of a national seroprevalence study, but that's the sense of where those samples came from and how they were selected.
And it's a fascinating study and very helpful because this background positivity rate, regardless of symptoms, helps us understand when we do the public health surveillance, we get those positive reports and we actually follow up with those patients to figure out, do you have symptoms or do you not? And so basically, we then have a denominator. That's what your seroprevalence data is a denominator. How many people test positive versus how many people are truly symptomatic. And that's what the public health case investigation work is really trying to do. And so it'll be very interesting to see and compare that seroprevalence data from those states to what they're going to do if they have alpha-gal reportability in those states, kind of how that works out. But it is a huge amount of work for those states, those high prevalence states. They were presenting a couple of them at the conference and thousands of positive labs to comb through. And so just the sheer amount of work that that's going to take for them is daunting in a time where public health doesn't have copious amounts of resources right now. So we'll see kind of how we get to the bottom of that question. Here on Martha's Vineyard, the data that we have is very different than random blood donors. The data that we have is from our hospital lab, where a physician or a PA or an NP decided, I'd like to test you for alpha-gal syndrome. I think you might have it, or I'm suspicious and I'd like to know. And so that's very different than a blood donor pool. And so the rapid change that you see on Martha's Vineyard comes from that data, because in 2020, 9 total tests were run, period. 2 were positive. In 2025, it's been exponential, really, year to year. In 2025, nearly 1,700 tests were run and 742 were positive. So massive difference. A couple things play into that massive difference. One is certainly more Lone Star ticks. We have very good data from Patrick and the tick surveillance he's been doing to show that we're having more Lone Star ticks in more places, and higher densities. They're very happy here, unfortunately, because of our deer population. They basically have a buffet available at all times. The other thing, though, is we've been very consciously creating more awareness around alpha-gal syndrome. Aubrey's been doing this, Patrick's been doing this, I've been doing this. And so by raising awareness, both among patients and providers, of course, then you have more testing. And then I will factually say it's not just awareness that's increasing. We definitely have more allergic individuals on Martha's Vineyard. We're working through that data collection right now. Alpha-gal syndrome is only reportable as of April this year. So public health has a lot of work to do to sort through all those positive tests and follow up with all those patients and figure out who's got symptoms and who doesn't. But it definitely has been a massive change in awareness and concern on Martha's Vineyard, a massive change in how many people are getting bites. And we can logically say, yes, there's more people who are allergic, but the amount of folks that are actually allergic is still a question. We don't have that number. And I often see this confused, especially in reporting, and because people don't live in epidemiology land like I do, and that's totally fine. But when the positive tests come through, those are not necessarily allergic people. And you have other studies, Scott, where you have looked at this and completely non-allergic people, your controls in your study, and 30% of them tested positive.
It's very true. And I think it depends where you are. I wondered, Aubrey, from your standpoint, like clinically, Lea sees this from the epi side, but does it mirror what you're seeing in the ED?
Oh, well, that's what's just so hard about this. And this study, for all the reasons, was super important. But for me right now, as a clinician, it's really helped. I think a lot of times patients are very upset with a clinician that won't just test them. Just test me. I just want to be tested. And a lot of time is spent explaining to these patients, to individuals, why we don't want to test without the symptoms. You may come back positive. And I think, I want to say, was it Eleanor? Lea, were you at this talk that Eleanor gave, one of the ID crew down there, about if you take 100 children and you check them for a peanut allergy, 10 of them are going to have that IgE sensitivity to peanuts. One of them will actually have an allergic syndrome. And I use that as an analogy. Now, we don't know right now, as we gather this data, and hopefully we will, how many of those 100 people are going to test positive. But we know, in many cases, at least 30%. I think we saw that replicated in other people's studies too, that 30% of a given population may be sensitized without actually having the syndrome. And having this now data from MMWR, and granted, we don't know what the symptom profile of these individuals are, but it's further evidence for, you may not know what to do with this test. This is not a good screening test. If you have symptoms, it can be really helpful. So, in the clinical world, I'm still getting asked to test constantly. And I've actually, unfortunately, had to have some very gentle conversations with other clinicians locally who are simply including the alpha-gal test in their tick panels. I mean, I'm like distressed because the number of patients that are going to come back with a positive test are not going to know what to do with that information. And again, given the vague symptoms that can often accompany alpha-gal syndrome, they may interpret any symptom that they have, whether it's, GI upset on a given day or an itchy rash, as, oh, I have the syndrome. So I'm really hoping that as we collect more of this data, especially on an island where, I'm very curious to see, if we were to take a pool of 1,000 patients and test them here, what our seroprevalence truly is going to be. So that data is going to be very interesting and probably somewhat different than it is in other places. But this is helping me reassure patients that a positive test does not necessarily mean anything in terms of changes that you need to make to your life when you don't have symptoms. So I'm very curious to see as we collect more of this, because I think it's going to help hopefully relieve some anxiety for individuals who, as we talked about at the conference, there's this sense here by a lot of people that it is inevitable that they are going to develop alpha-gal syndrome, and they're sort of just resigned to this happening. And I think they're confusing the testing positive with actually having the syndrome?
The opportunity to have a better test would really alleviate a tremendous amount of angst and obviously false positive or sensitization testing, because the data seem to show over and over again, if you're in the right geographic area for Lone Star ticks, it's not crazy to think that 30% of people could test positive and that 30% would have no symptoms whatsoever. That's just your background rate.
And what are those, we talked about priorities. It's so interesting as a clinician. I want to know, as I'm sure every patient does too, what are the characteristics or, or phenotypes that set the people who develop the syndrome apart? And once we know that, it's really going to help us hone in on who's more at risk. Right now, it's sort of anybody's guess.
Yeah. I mean, you probably do as well. You talk to like spouse or partners where one of them gets a lot of bites and doesn't have the syndrome at all, but yet the one who is unlikely to get tick bites gets one bite and ends up with AGS. And we don't know what that risk factor is on the host side.
We definitely also need to study those couples where one's a tick magnet and one is not, about what is it also about you that makes you protected from tick bites. That's another study I'd like to see, because ticks detect their host based on carbon dioxide output, but also vibration and heat. That's what we know of. And are you walking clunky? Like, what is it that are making you a tick magnet or not? And is there something to be learned here? Or is it completely out of your control? It's not behavioral at all. Like, and how do we bottle it? How do we make ourselves invisible to ticks? It almost makes me think of like the World War Z plotline, where at the end of it, they make themselves invisible through an intervention basically to the zombies. I'm like, how do we make ourselves invisible to the ticks?
I love that. That's actually great. No, it's true. It's really true. I definitely feel like as with other tick-borne illnesses, there's a subset of people that have had a bajillion tick bites over and over again and absolutely never test positive for anything. And then others who are like, hi, I've been outside 3 times and I've had Lyme 12 times. What's happening? There's definitely something there that we just don't know yet. Or maybe it is just dumb luck. But that would be excellent information to be able to share with patients.
When y'all are calling people either for reporting or for a clinical follow-up, do you get asked much about what the number means?
All the time.
The specific IgE? Like,
Yes.
my
Yes.
number is 10, and is that good or bad? Or yeah.
Yeah. I think one of the big take-home points when I give some information publicly, but also with the patient, is to not compare to their friends. I get that a lot. Well, my brother tested positive. His number is 100, and my number is only 82. And why am I having anaphylaxis? And he just gets GI upset. And really having to impress upon people that comparing between individuals is not helpful. It may be helpful for you to track your number as it goes down, but also helping. And correct me if I'm wrong, my understanding is that the IgE, even within an individual, is very dynamic, depending on the moment, even, or recent tick bites, and how hard it is to really rely on that. The other thing that frequently happens is I have patients come into the ER for something other than alpha-gal, and while I'm drawing labs for those things, they're like, can you also check my alpha-gal level? I want to see if it's gone down. Sometimes I'll do it if it's been a while. I think a lot of times there's something to be said for giving patients a little bit of reassurance to see that they have a downtrending number over a year. It doesn't say anything in the moment about what recommendations I'm going to make, but people do seem to be very consumed by those numbers and what they mean. Yeah. Do you have any thoughts on, what we can tell a patient about what to expect from their allergic response if their number goes down significantly? A lot of times they ask about, when can I start a food challenge? When can I put meat back into my diet if they've not been able to tolerate meat? My number went from 50 to 12. Is it safe now? What are your thoughts?
I usually try to let dairy lead some of that, because if you can't eat a slice or two of cheese pizza without having hives and GI distress, then you're not ready for
Right.
hot dogs and hamburgers, right? it does seem as though over time, if you're not getting more bites, that the allergic compartment, or, you know, we would call it the Th2 aspect of the immune response, that allergy portion that had expanded from the tick bites seems to contract. Evidence suggests that alpha gal allergy is not a permanent one. It does not seem to make like long lived memory cells. It makes these immature, more sort of like a, we call them a plasma blast, but you might think of just a young cell that never really becomes a long lived memory cell. And they seem to want to basically kind of die off, if not re-stimulated by additional tick bites. So I ask people to think about the number more as a reflection of their recentness or perhaps their avoidance of ticks. So all of the great tricks that we've talked about, that Lea has helped share, like all that is time well spent, because that, I'm like you, Aubrey, I do check the number because I think people are invested in their avoidance techniques, and we want to support that. And one way to do that is to demonstrate that their alpha gal IgE is downtrending.
Yeah, that's interesting to know. I did see a handful of the studies that you participated in where we actually see a very clear correlation between the level of both the alpha gal specific IgE antibody as well as just an IgE
Mhm.
go up in a predictable fashion shortly after additional tick bites and then come back down again, which really helps us again with the messaging of prevention of tick bites in general, so that we hopefully don't ever develop this allergy, but also when patients ask the question of, am I ever going to recover from this? And I have had patients have said to me, I'm never going to get rid of this. I've had it for 5 years. And they didn't understand, because I don't think anyone did at the time that they might have been diagnosed, that it's the additional tick bites that are potentiating things for them, which is a problem here because a lot of times, especially with the nymph and the larval ticks, these tick bites often go undetected because they're so small. And again, given our huge tick burden locally, it's a real challenge for patients to definitively avoid additional tick bites in our environments. On that note, I have to go. I'll chat with you guys soon.
Okay. Take
Okay.
care, Aubrey.
Thank you. Bye.
Before I let you go, I wanted to get your thoughts on how you see differences between Martha's Vineyard and the neighboring Nantucket Island. And like as an epidemiologist, and I know you know a fair amount about the ticks on both islands and the geography, like, is Nantucket needing to brace for something similar, or is Martha's Vineyard unique and different, and what's happening is not going to be an issue on Nantucket?
I've learned to not bet against Lone Star ticks. And so I would place my bet that they are just behind us. And that's kind of what happened with us versus Long Island. Long Island has had a bear of a time with Lone Star ticks 10 years prior to us in terms of how they saw that acceleration. And so when we started seeing Lone Star ticks show up on Martha's Vineyard, we actually turned to Long Island and said, what can you share with us? What do we consider you to be 10 years in our future? What do we need to know? And so with that, we didn't beat alpha gal syndrome or Lone Star ticks on Martha's Vineyard, but we matched the increase in terms of our outreach and awareness and engagement. I have learned that it's really difficult to warn people of what's going to come. I have a lot more empathy for a whole lot of scientists, especially climate change scientists, about how difficult it is to warn people and actually solicit behavior change or action based on something they haven't seen yet. But I do think that Nantucket has all the ingredients to go the exact same way we have. They actually have more deer per square mile than we do, which is hard to believe because we average 50 deer per square mile on Martha's Vineyard. They average 80. They have all the food that a Lone Star tick population would ever need to be able to establish and proliferate. And they are seeing more Lone Star ticks on their island for sure. And how they get there, either again, the theory of pets. There's a lot of people coming and going from both of our islands, as well as potentially ground nesting birds. But I've at the conference was talking to some of the tick scientists, and they were putting their money on pets. But there are Lone Star ticks being found on Nantucket more and more every year. They're not where we are now, but they're headed in that direction. So I don't bet against Lone Star ticks, unfortunately.
Are there things that you would potentially recommend that Nantucket should do? Or is it kind of like your point, you don't bet against Lone Stars and they're probably just, this is almost inevitable?
Well, when we were in this situation and when we first found Lone Star ticks established out in a corner of the island, Sam Telford, who's been doing research here on Martha's Vineyard and the islands for 30 years, he's a Tufts University researcher. He said pretty pointedly, you better take care of that right now.
Wow.
He warned us.
Okay.
And how you would take care of it might be a acaricide spraying. And to convince a ecologically delicate island to take that level, not knowing what's to come, is again this difficulty of warning people who don't know necessarily what's going to happen against what they also are trying to protect, which is an ecologically fragile island. So we don't have phenomenal tick control solutions. But if you do detect Lone Star ticks, and that requires a lot of manpower looking for them, because it's not easy to find ticks everywhere and anywhere on a whole island. Like, you need the manpower to cover that. But to try and stamp out the foothold is something that might work. Again, we didn't do it. We didn't even try. So hard to say if it would have worked.
Are there aerial interventions that does it all have to be on the ground?
Great question. For mosquitoes, there's aerial interventions, but largely mosquitoes fly. And so any sort of aerial intervention might hit a mosquito on the way down and then kill the mosquito. With ticks, because really the choke point for ticks, where you're going to find ticks, is when they're looking to get a blood meal, when they're looking to feed. And so the choke point in their life cycle is really on animals. And otherwise, they fall off the animal wherever they fall off in the environment. It's not preferential. They're not thinking, oh, this is a good place. I'm going to hop off here. This is my stop. They fall off wherever they're done feeding, and then they just hang out under the leaf litter until for like 6 months to 8 months to a year. And they're not looking to do anything. They're just there. And so even spraying, if you wanted to go full napalm, which we do not want to do for so many other reasons,
Right.
but it wouldn't work because they're underneath the leaf litter, protected in a way. And so the pesticide wouldn't get to them and they'd still be there. And so that's a really difficult thing. So we keep on coming back to probably the most efficient and logical way to deal with ticks is on animals. And there's scientific pursuits now to either figure out, can we medicate animals like we medicate our dogs, where they become toxic to ticks. And so when the ticks bite the animals, they die. Or is there, their fur be treated? Like, that's a situation that they're doing with mice, where there's these little mice boxes and that only works for deer ticks, by the way. I would like to say in this podcast right here and right now, Lone Star ticks prefer larger animals. They do not bite mice. They don't bite rodents. the deer ticks do. And so it's a phenomenally complicated system that we're trying to influence when we have multiple types of ticks because they have different preferences and different habitats. But the Lone Star likes house cat size and larger. And they really love deer. And so if we can figure out either how to medicate deer or vaccinate deer, that's another possibility. But that technology is not immediately available. It's going to take some time and some effort, but potentially we could vaccinate deer. And we have vaccinated wildlife before. That's how we've actually dealt with rabies. So,
so there's precedent.
Yeah. So that's how we deal with rabies in the United States is we actually give oral vaccines and we put them out in the environment and hope that those little critters eat them up so that they become immune. And so that's a possibility. But again, we're going to need a lot more science to get there. But in terms of like actually controlling the amount of ticks in our community, we definitely need more investment, more science, more resources focusing on that. Because I'm very interested in prevention with a capital P at this point. We need to get to source control at this point.
Wow. I think that's an incredible point to end on too. Lea Hamner, I thank you for your insight, expertise, and all that you're doing on the public health side to keep people safe and spread the word, raise awareness.
Thank you so much for having me, Scott. Always a treat. Appreciate the time, and I learned things today, which is always a good day.